Recorded.
We had around 112 patients of MISC. It's an unpublished data we are planning to publish. So I would just touch upon it at the end of the presentation. So we all know that blood culture is the gold standard whenever you are suspecting a bacterial sepsis or any sepsis. So that is what has been practiced throughout since ages. But there are certain points that may affect the yields of microbiological cultures, which can include like that if it is an intermittent bacteremia not causing a significant sepsis. Again, sometimes we get to see blood culture positive, but child is doing very well, and sometimes you get the child be with lot of sepsis, but there is no growth in blood culture because of very small or undetectable bacteria. The bactericidal properties of blood components or the antibiotics that has been previously used, the volume of blood, especially in children, there are many a time situations where adequate volume of
Ashok Kumar
blood cannot
தனியா
be
போயிட்டு
drawn
அனுப்பிச்சிடலாம். கிளாஸ்
in,
நடந்துட்டு இருக்கு.
in a
ஸோ
normal.
அசோக் குமார் இருக்காரான்னு கேட்க சொல்லுங்க.
So these are the situations where, yeah, and concomitant antibiotic use, number of sample. So there are a lot of drawbacks in microbiological cultures, which makes it difficult to make a clinical decision based on microbiological cultures alone. So then there is a therapeutic conundrum, even not even for an ICU clinician, but also for a practitioner who sends the investigations for a sick child when the child comes to the OPD. So the dilemma is whether to initiate effective antibiotics immediately, or whether to wait for the reports, or practice some stewardship program, like we are waiting and we are convinced enough clinically that this child won't deteriorate. So how to make this decision? The other point is, we also know that there is no single rapid and accurate diagnostic test. If you send a blood culture, the sensitivity will take around 72 hours, and if the child deteriorates within that period and we do not start antibiotics, is it going to become a problem? And what kind of antibiotic should we start? Should we start a baseline antibiotic, or should we immediately go with a broad spectrum antibiotic? These are all the therapeutic conundrum that we face on a day-to-day basis in our daily practice. So that is why people have tried biomarkers, and we are all using biomarkers for quite a decade now, just to differentiate like whether this child is in sepsis or not. Because all what we are concerned predominantly when we are sending investigation is this child sick enough, and will this child give us time to evaluate in OPD, or is this child going to deteriorate soon? Will this child require an inpatient admission to monitor? So that is very difficult, because we do understand that sepsis has a complex pathophysiology, and there are a lot of heterogeneous interactions in determining this. There is no gold standard diagnosis, no tool. And nowadays we are relying on biomarkers, and multiple biomarkers are there now available, which include CRP, procal, IL-6, ferritin. Sometimes people, they use even platelets as one of an indicator, neutrophil lymphocyte ratios, total count, which is a standard and old marker for infection. So all these things are available in the market. So what is a biomarker? A characteristic that is objectively measured and is evaluated as an indicator of normal biological response or pathogenic process or pharmacological response to a therapeutic intervention. So we have to get all these information. When you come to the history of biomarkers, we found that at 1927, the leukocytosis, total leukocyte count as a marker of infection, it was established in 1927, and this practice is followed even till now. And along with this total leukocytosis, we now look into CRP. It took around, for example, 60 years for us to come to identify that yes, we need additional information, and there is a lacunae with culture. So came C-reactive protein. And then in 1989, soon people thought like CRP predictability is a bit haywire, so we have to have a more sensitive biomarker. So 1989, IL-6 came into the picture, and in 1993, procalcitonin came into the picture, 2000 TREM molecules, and then 2011 they went into genomics, and so it is evolving. So you can see like from 1980s to 2017, in the span of the next 4 decades, the research amongst the biomarker, it gradually increased. So mostly we use biomarker for diagnostic, prognostic, and theranostic indications. But in our OPD practice, when you are going to sit in the OPD, predominantly you are using biomarkers only for a diagnostic purpose. So we are concentrating now on diagnostic biomarkers. So whether to distinguish it between the infectious versus non-infectious causes, and what is the probable causative organism, whether we can distinguish that by using a biomarker, and we can whether predict that this patient will require admission and then a follow up or an IV antibiotic, or whether this patient has the predisposition to deteriorate. So we are mostly concentrating on the acute phase reaction, because usually in the OPD, child comes to you on day 2, day 3 of illness. So mostly we are concentrating here on the acute phase reaction. So as I said before, the research in the field of biomarkers are gradually increasing in the past 2 decades. Which are there. So what every research concentrates is in this process. There is an infection which is resulting in inflammatory response. So we are trying to tap at this point to identify what are all the molecules which are increasing, and whether that predicts recovery or that death or that predicts organ discharge. So these are our predominant way that we can find with initial inflammatory response. Are we able to determine the outcome of these patients, so that by determining the outcome, we can start effective therapy initially. So when there is a inflammation, that pathogen associated molecular proteins and the damage associated molecular proteins will trigger the immune system, and sometimes this immune system trigger can cause tissue injury. So immune system trigger can release chemokines. This is the earliest process, like IL-8, IL-6, TNF alpha, interleukin 1. This will trigger the liver. This liver will generate CRP. Sometimes this procalcitonin has an alternative pathway where this chemokines and the inflammation per se will cause tissue damage, and this tissue damage releases procalcitonin. So these are two different pathways. One is throughout the release of chemokines, and these are at multiple stages. You have interleukins, and then that will stimulate to produce an acute phase reaction like CRP. The other is directly from the damage of the tissues. So based on this, what we need from an ideal biomarker is there should be a fast kinetics, meaning as soon as the insult happens or the point at which you want to detect happens, the biomarker should be detectable. It should be at a low cost for an office practice, and there should be a short turnaround time. It should be linked to main underlying processes, not as it can raise for every other condition. It should be linked to the process that you want to identify, and it should be a point of care test. It is better that if you have a biomarker with a point of care test, your patient is there in your OPD, like a blood glucose, you just do it, you are able to find it. And then it should have a high sensitivity and specificity. So satisfying all these 5 criteria, it is very difficult to get an ideal biomarker. And how are we able to get the ideal biomarker? This is one important parameter in statistics that we should all know. All biomarker research, they will look into the ROC curve, or the receiver operating characteristic curve, and the area under the ROC. This is the area under the ROC curve. So this will determine whether your biomarker is a good predictor or a worthless predictor or an excellent predictor. So if the AU-ROC values are between 0.9 to 1, then it is an excellent predictor. If it is between 0.8 to 0.9, it is a good predictor. So any AUC more than 0.8, we say that this biomarker has a good predictability of, value for your particular outcome. So coming to a case scenario of a 4-year-old child, and this child is a female child. The child is having a high-grade fever with blanchable rashes, mild pedal edema. Child is having tachycardia and tachypnea. So child is having all features of systemic inflammatory response syndrome clinically. And child has received antibiotics for the past 2 days in an hospital, or you can even take an oral antibiotic prescribed by some other person. So once when you do a test, you find that once you do a test, you find the possibility could be sepsis, or whether this could be an inflammation, because your TLC is high, your DLC is showing 77% neutrophils, your platelet is falling down, your CRP is a bit high, and your LFT, all your organ function tests are completely normal. So here you have to make a decision whether to start the initial treatment, and if that initial treatment, like previous person, whether it should be an IV. Obviously, the child is having clinical features of tachypnea and tachycardia. So you will go with IV, and you will see whether what is the process, whether it is antibiotic is definitely required or antibiotic is not required. So why did we start this? Because your CRP is high and there is a clinical symptom. So we combine the clinical symptom and the CRP. So what is the CRP? We all know that it is acute phase reaction and it is IL-6 driven. So CRP is a surrogate of IL-6, but it rises after the IL-6 levels go up. So it is not before IL-6. If CRP is high, IL-6 might be high or might not be high, but if IL-6 is high, then CRP will definitely go up. And CRP level can increase in sepsis and septic shock even to 10,000 fold greater, meaning a normal CRP, if it is less than 0.5, it can go up to even 500 or 600. So this is a normal graph of CRP, where you can get a rise in CRP at 24 to 48 hours of infection. Then you can see the fall. The fall doesn't happen rapidly till 5 to 6 days. And then there is a rapid fall and normalization of the CRP. So compared to all other previously known biomarkers like haptoglobin fibrinogen, CRP seems to be a better biomarker. So we know that it peaks between 36 to 50 hours, and it reflects the magnitude of the inflammatory stimulus and the sepsis severity. Biggest advantage of CRP is that it is easily available and the cost is very low. You can do a CRP in your OPD setting at a very low cost. The serial use and therapeutic response assessment you can do with CRP, and it is not affected by immunosuppression, meaning you can do CRP for children with who is on steroids or who is having renal dysfunction. That is the biggest advantage of CRP. The disadvantage is in children who already have an existing liver failure, we should not rely on a CRP value. But whether can it discriminate patients with and without infection? CRP is a marker of inflammation, but is it a marker of infection? So when we go into the serial studies which has been done with CRP, we find that there are varying sensitivity and specificity values of CRP, and many studies have used different cutoff values of CRP. So like from 4.4 milligram per deciliter, people have evaluated till 40 milligram per deciliter. And mostly what we find is this 40 milligram per deciliter has a good sensitivity and specificity, because sometimes when your value is too low, your sensitivity might be up, but at the same time your specificity might go down. So a CRP at 40 milligram per liter, it is showing probably the equivocal sensitivity and specificity, meaning you can be like, if the CRP is more than 40, then definitely the specificity is more. You can say like this child is having a bacterial infection. If CRP is less than 40, your child may or may not. So this we call it as the negative predictive value. And normal CRP definitely rules out a bacterial infection, whereas a high CRP may be bacterial or may not be a bacterial infection. So based on high CRP, you cannot distinguish whether your child will require antibiotics or will not require antibiotics. But if the CRP is normal, you can wait. You need not start antibiotics, but that also has a lacunae. I will come to that. Second thing is for adequacy of therapy. So this graph, why I want to show is, this is a study which has been done with around 36 patients. And here what they observed is, once you start on antibiotic, they decided to change the antibiotic based on CRP values. They found like initial 24 hours in both in the both different patient groups where they changed the antibiotic clinically or they did not change antibiotic, there is a rise in CRP. So rise in CRP at 24 hours is usually observed, and based on this rise, you should not decide a change in antibiotic. But at 48 hours, if there is a rise, it is correlated clinically with clinical deterioration, and then changing an antibiotic at that point has found a response. Here, when there is a fall at 48 hours, even though you don't change antibiotic, child is able to attain the same clinical response. So CRP, when you're doing on day one, if you are finding that your CRP is normal, it is better to repeat on day after 48 hours to see whether there is a rise or there is a fall. Or you have started antibiotics, you repeat the CRP after 48 hours to see whether there is a rise or fall. If there is a fall in CRP after 48 hours, then probably your infection is coming under control. But if it is a rise in CRP, that is more predictive. A rise in CRP at 48 hours means that your infection is not coming under control, your inflammation is not coming under control. Therefore, there is still an ongoing infection, and you have to consider changing your antibiotic. CRP as a predictor of mortality. Yes, obviously all children who has higher mortality risk, they have a higher CRP value. This is found in a meta-analysis between survivors and non-survivors. So CRP generally is used to guide the duration. In fact, more than guide the duration, it is helpful to determine whether escalation of antibiotic therapy is necessary or not at 48 hours. And it is also helpful to reduce unnecessary antibiotic usage. Meaning if your CRP is negative when you're doing the test, most likely your child is not having a bacterial infection, and it can suggest whether the initial antibiotic therapy is ineffective or not. So what are the limitations of CRP? Obviously, CRP, it lacks the specificity. There is increase in other inflammatory and all. It is increase in inflammatory conditions also. So it is not able to distinguish between bacterial and other infection. And lower levels of CRP should be interpreted with caution in children with hepatic failure. So since there are all these limitations, we went into procalcitonin. What are the advantages of procalcitonin? There is an immediate rise after the insult. As soon as the infection occurs, procalcitonin rises within 4 to 6 hours and it peaks in 12 to 30 hours. Its half-life is so short. Therefore, as soon as the infection recovers, the fall is also dramatic. So if your procalcitonin is falling significantly, which means like your infection is clearing out, and people have also found algorithms to stop antibiotics depending upon the fall in procalcitonin level. It suggests like the infection has resolved completely. So it is helpful in discriminating between infectious and non-infectious inflammation, difference between viral and bacterial infection, and whether it is gram negative or gram positive. And also in a patient who has viral infection, whether they are going into a secondary bacterial infection or not. So these are various cutoffs that are used for procalcitonin, but the limiting cutoff is 0.5. If the procalcitonin is more than 0.5, then probably this infection is systemic and this child will require a systemic or an intravenous antibiotic therapy. And if it is less than 0.5, a oral antibiotic therapy, or if it is less than 0.5, if you find that there is a focus of infection, you can treat it even with a topical or specified therapy based on the clinical condition. So here you can see these are studies which demonstrates that in a serious bacterial infection, procalcitonin is significantly high as compared to WBC counts. And also it has observed that the area under the curve, as I said to you in the initial slide, the area under the curve of procalcitonin is 0.834, which means it is a very good marker to predict a serious bacterial infection. So then comes what is the cutoff. As I said before, for serious bacterial infection, usually the procalcitonin cutoff that we take for any infection is 0.5 and more, which means like there's a systemic bacterial infection, and 2 or more, definitely it says the illness is very severe. These are the area under the curve. You can see almost all area under the curve is more than 0.8 in several studies, and in some studies the area under the curve is up to 0.94 to 0.95, which means like it has a very good infection. So here you can see the cutoff of 0.5 and here the cutoff is 1. So any cutoff more than 0.5 itself is a good sensitivity as well as specificity. As compared to CRP, procalcitonin has a much better sensitivity and also has a much better specificity. When you look into the positive and negative, why I am showing this study is this study has the highest number of volume, around 445 patients between 1 to 36 months. So here they found like, and this study, both these studies, they observed that the sensitivity as well as the specificity of procalcitonin is much better as compared to the previous data that I showed for CRP. So as I said before, procalcitonin are also used to stop antibiotics, but this is usually people have done these trials in adults, but in children we don't have a specified cutoff. Recently in children there are studies which are ongoing and we base our antibiotics based on these procalcitonin cutoff value. Less than 0.25, you need not start antibiotics at all. 0.25 to 0.5, it is better to discourage if your child is not clinically toxic. More than 0.5 and less than 1 antibiotics are encouraged, and more than 1 antibiotics are strongly encouraged. So coming to this example, this is the fallacy of CRP. I said normal CRP you can wait, but sometimes why we should do procalcitonin? A child who is on having a good general appearance, your CBC, WBC, CRP is normal, but sometimes the procalcitonin, if you do, it is 0.5 to 1. So procalcitonin rises much early. You send this child home, then the child develops high temperature, illness is evolving, and if you find a procalcitonin of 0.9, the child brings with you the report of 0.9 on the next day, then probably you should think like, okay, yes, this child is probably having a bacterial infection and we have to start antibiotics. So the rapidity, the early diagnosis, the sensitivity and specificity is much better if your child comes the next day, and on the next day even your CRP will rise. So instead of repeating the CRP on the next day, on day one itself you send the procalcitonin value. In an affordable patient, it would be helpful for you to take a decision on next day for antibiotics. So guideline of stopping antibiotics, usually we stop antibiotics if the concentration is less than 0.25, and suppose between 0.25 and 0.5 also we can encourage stopping antibiotics. Any concentration more than 0.5, antibiotics needs to be continued. This is for infections which are long standing. Previously there are guidelines which said, okay, if there is an empyema you have to give 4 to 6 weeks, brain abscess 4 to 6 weeks. So the antibiotic duration was based on the diagnosis, but now we are slowly moving towards stewardship, and procalcitonin is one of the promising biomarkers we are looking into for stopping antibiotics. That is because of the significant steep fall once the infection resolves with procalcitonin. So what is the problem with procalcitonin in a very early infection? Like if the patient comes like, just now fever happened, I am bringing the child to you. So it has not even happened 6 hours, your procalcitonin is not going to have any value. Not even procalcitonin, your any investigation of biomarker is not going to be of any value at that point of time. Localized infection, your procalcitonin values might be low, and in subacute bacterial endocarditis, your procalcitonin may be falsely negative even though there is an infection. But sometimes it can be falsely positive if there is a significant inflammation. For example, in ARDS, malaria, systemic fungal infection, mechanical and surgical trauma, significant trauma, chemical pneumonitis, in some cancers, and even our COVID. Even though COVID is a viral infection, when there is a significant inflammation produced, your procalcitonin can be falsely positive. So still it is not a completely foolproof biomarker, but when compared to CRP, procalcitonin has advantages. So if you have to do only one biomarker in your OPD to determine whether you have to start antibiotics or not start antibiotics, and the patient is affordable, you can go for procalcitonin, or else CRP is still preferable for outpatient setting. Now coming to ferritin. Ferritin nowadays has gathered more and more more and more knowledge on ferritin has come because of the evolution of dengue and hyperferritinemia, and we all know that we are all come to terms that if the ferritin is high, it means like this particular child, they have the potential to deteriorate, but we are still unsure how high the ferritin should be and whether this ferritin should be done in all patients, and how this is going to determine my clinical practice. So that is one particular thing that is still research is evolving. So coming to this study, which is done in Brazil for 36 children, they serially measured the serum ferritin levels at the time of diagnosis of sepsis, and they calculated the ferritin index, which is the serum ferritin of the topmost serum ferritin divided by the normal limit of the ferritin level, uppermost limit of the ferritin level. And here they found the ferritin level more than 500 in patients with sepsis, they had a mortality risk of 58%, and it was associated with death. And ferritin index of 1.7 was the best cutoff value to identify that this patient is going to have a severe infection. So in another retrospective study, they found like all patients with tested for serum ferritin from September to August, and they took around 5 years with a level of more than 1000, and the outcomes were mortality and ICU admission. So which all patients they will require ICU admission if the ferritin is more than 1000. The total number of patients were around 171. So here they observed that in our situation, this is very practical. In dengue, we know that obviously the ferritin is going to go up. So any ferritin level which is more than 3000, they have the highest risk of mortality. So as compared to 1000, more than 3000, they have highest risk of mortality, and they have a significant risk of multi-organ dysfunction. And when they categorize this dose response, like they divided between the survival of 1000, 3000, 5000, 7000, 9000. In each successive levels of rise in ferritin, they found that the survival is going down, which means like ferritin, the value of ferritin is directly correlated with the survival chances of the child. So ferritin as a marker is very important in determining the severity of infection. CRP and procal we use to diagnose the infection, but ferritin is a very important marker to determine the severity of infection. When the CRP is high, you don't say the infection is very severe, or procalcitonin is high, severe. But if your ferritin is high, if it is more than 1000, definitely your infection is severe. And if ferritin is increasing, the severity of your infection, severity of your organ dysfunction is going to increase. So when you combine ferritin with CRP, how to interpret? So there are three possible groups. So a high risk group, this is one study which had done this. They combined ferritin and CRP, and they found that there are three groups: the high risk group, the low risk group, and the intermediate risk group. The high risk group is which has both high CRP and high ferritin. Low risk group has both low CRP and low ferritin. Intermediate risk is any one which is high. Some patients will have high CRP and normal ferritin. Some patients will have high ferritin and normal CRP. So based on this, the optimal cutoff that they used for ferritin and CRP was 4 for CRP and 1980 for ferritin. This is what they found in the ROC curve. And they observed that the mortality was clearly higher in high risk group, meaning a child which has high CRP and high ferritin, definitely this child is a high risk child, and this child will require a referral to a tertiary care hospital with intensive care backup, because the mortality risk is very high. Intermediate group, it is lower, but if both are less, this child has a very less chance of dying. So there is no risk in this particular child when your CRP is normal and your ferritin is normal. So coming to our experience, so we had around 112 children. This is pan-India data, like this involves throughout India, from the north zone, central zone, south zone, and as well as the east zone. So this is a pan-India data, which also includes Chennai. So here we found, out of all the laboratory parameters in COVID, because COVID is something which is very confusing. It is a viral infection, but we find all the inflammatory markers to be high. So in such a situation during the COVID era, is your inflammatory biomarkers going to be helpful for you like before to determine whether you start antibiotics? The procalcitonin, if it is high, then it is likely to be bacterial. So in this COVID era, it is going to be helpful, or this child can also be having a COVID related MISC. What we found is that all the inflammatory parameters, they are elevated, and it is very difficult to distinguish. Even procal, what we observed this procalcitonin, we differentiated this COVID MISC into three categories. This is the first category, which says like this is COVID, PCR or antibody positive with signs of inflammation, with inflammatory markers which are high. This is COVID with PCR positive or antibody positive. This is category 2 with coronary dilatation on echo. This is COVID PCR or antibody positive with signs of organ dysfunction and no coronary dilatation. So these are three different categories or subgroups that we divided the patient, and each subgroup had around 30 to 40 patients. So here what we observed is, this is the severe group. This is a group which had coronary dilatation. This is a group which had only COVID and inflammatory markers rise, but there are no other signs of significant organ dysfunction. So out of these three, we found that procalcitonin was a very important predictor of severity. So procalcitonin is high, then probably this child is having hypotension and organ dysfunction. And along with procalcitonin, your ferritin. So these two markers, they were predicting severity in COVID antibody positive patients. So if you are in a clinic, you are suspecting MISC, you do these two tests, you find that the ferritin is high or procalcitonin is high, then it means like your child is having a significant inflammation because of MISC. Your CRP is not predicting. CRP, even with CRP and inflammation and no organ dysfunction, it is 158. There is no significant difference between CRP amongst the three group. But your procalcitonin, there is a significant rise. You see, even with coronary dilatation, procalcitonin is high. So if procalcitonin is high, definitely this child is a child which will require monitoring. And also if your ferritin is high, which means like your child is going to have a significant severity with multi-organ dysfunction. So when we did the ROC curves for all these patients, we found the highest area under the curve is for ferritin, the serum ferritin. So if your serum ferritin is high, definitely this child is a candidate to go into the ICU for monitoring of organ functions. If your D dimer, next comes your D dimers. If your D dimers are high, again this child is a child who has to go into ICU. The cutoff is 500 ferritin gives you a sensitivity of around 85% and the specificity of 80%. And D dimer also the cutoff is more than 1. But when you take IL-6, it is not faring good. Your procalcitonin is not faring good to determine the severity. So if your procalcitonin is high, it could be either the child is having a coronary dilatation, something like KD-like picture, or it could be having a multi-organ dysfunction. But if your procalcitonin and your ferritin are high, then this child probably will go in for multi-organ dysfunction. CRP is obviously not significantly predictive, and your neutrophil lymphocyte ratio is also not going to predict the severity in COVID MISC. NL ratio, people have found it can predict the severity in acute COVID PCR positive infections, but MISC, this has no prediction towards the severity of illness. So in our COVID data, this is the largest data of around 112 patients. We find like the utility of biomarkers with ferritin combined with CRP or procal. Procal is high, ferritin is high, definitely your child has the potential to deteriorate. If only CRP and procal is high, ferritin is normal in COVID, then there is very less likely chance that this child is going to have a multi-organ dysfunction. But you do an echo, if there is a coronary dilatation, you give IVIG and a pulse methylprednisolone. So thank you, and be free to take up any questions. Any questions? You can put the questions in the chat box also.
What about C-creatine value in 6 milligram in our peripheral area? CRP value 6 milligram, the rural area.
Yes, sir. So CRP value 6 milligram per deciliter is not significantly suggestive of a bacterial infection. But if CRP is less than 6 milligram per liter, then definitely there is a very high chance that your child is not suffering from a bacterial infection. So if it's more than,
you are telling us below 0.5, whereas our lab rural area they are telling 6 milligram value.
The procal is 0.5, sir. Procalcitonin is 0.5. CRP is 4.
No, CRP they are giving less than 6 is normal. 6
CRP
milligram.
It varies from 4 even up to less than 10 in certain laboratories. They give it as normal. But definitely for you to consider CRP to be abnormally high, the optimal cutoff which will give you a good predictability would be 40. 40 milligram per deciliter.
0.5 is, you are telling is 0.5.
Normal. That is for procalcitonin, sir. Procalcitonin.
Yeah, CRP also you told 0.5.
No, sir. CRP it is either 40, more than 40, it is suggestive like you can start antibiotics upfront. If it is less than 10, then definitely less than 10 or even less than 4, definitely your CRP is less and you can wait for starting antibiotics.
In our area, rural area, they are giving less than 6 is normal, above 6 is a bacterial infection.
No, sir.
Above 6.
40 is as a predictability for a bacterial infection.
Okay.
Yes, sir.
Thank you.
So how does IVIG help in dengue encephalopathy? So madam, dengue encephalopathy is a very broad terminology because dengue encephalitis as well as encephalopathy clinically presents in the same way, and there are multiple mechanisms for that. One is direct viral invasion, second is antibody mediated, and third is the response like post dengue infection. or ischemia induced or shock induced encephalopathy. So if the child is in the second phase or in the critical phase of dengue, the dengue encephalopathy, probably we have to concentrate more on correcting the shock. And in this particular we will do an MRI if there is obviously a secondary immune mediated kind of reaction which is suspected. Meaning there is no direct encephalitis picture. It is predominantly encephalopathy or ADEM kind of a picture. We will go with IVIG for the when the encephalopathy develops in the critical phase. But sometimes what we see is dengue children presenting with raised ICP on day 2, day 3 of illness. So here on day 2, children developing encephalopathy or encephalitis is due to direct viral invasion. So here we have to address the viremia. So in order to address the viremia, we give immediately IVIG. So the role of IVIG is different when you use it in two different circumstances when it comes to dengue. Initially, you give IVIG to control the viremia. And second, in the second phase, when the encephalopathy is due to immune-mediated reactions or demyelination or any other condition, there you are going to address the inflammation. So IVIG helps also to control viremia when you give it in the initial phase. And second is, your child is in the second phase, it will control the inflammation. So these are two different distinguishing roles of IVIG in dengue encephalopathy. And if it's a single marker, what is the best? Is it CRP, Procal, or ferritin? Procal takes almost 1 day to come. What I would say is, if you have a single marker, it depends on the area of your practice. You all should know the limitations and strength of the biomarker that we are going to use, and we have to combine it with the clinical condition of the patient. For example, if you are in a corporate setup, like if in a very big hospital or in a transplant center or a quaternary care center, you are a practicing pediatrician in that center, your patient comes to you, your turnaround time for Procal is very less in that center. Yes, Procal would be a preferable single biomarker during that situation. If you are in a periphery like our Dr. Chidambaram sir, if you are in a periphery, you should weigh the strength and limitations. If CRP has a better, faster turnaround time, the cost is less, and you are accessible to that. You need not force the patient to do a Procal. CRP is sufficient, but you should know the limitation. As I said before, CRP value more than 40, more likely towards bacterial, you have to start upfront antibiotic. If CRP is negative, try to repeat the CRP after 48 hours if your child still remains symptomatic. If your CRP increases at that point of time, you have to decide on starting the antibiotic. So that is regarding CRP. Ferritin comes into the picture if your child is clinically toxic. If your child is clinically toxic, you do both inflammatory markers and ferritin. How this ferritin is going to help is, this ferritin will help you to decide whether this child will require prompt care or not. Like prompt care means will require a tertiary care center or not. Because high ferritin is always correlated with organ dysfunction and mortality. So if ferritin is high, better to have this child admitted in a good center which provides a complete care. So this is how your ferritin is going to help. So if you find a child clinically toxic, get a CRP done, also get a ferritin done. A high ferritin, this child has a very significant potency to deteriorate. So this child should be under care of a team which also has an ICU blood.
D-dimer is the indicator of a prognostic value or a diagnostic value? If so, what is the cutoff?
Listen. So D-dimer is now coming predominantly because of this COVID-induced MISC. The previous data, like the data published from the West, they found like D-dimer is associated with not severity. D-dimer, if it is high, it is found in children with COVID and MISC. In this data, we actually analyzed its predictability for severity, the one that I had showed you of around 112 patients. What we observed is D-dimer, the increasing D-dimer, they suggest like, yes, this child is probably having a risk for either coronary dilatation or this child is having a risk for organ dysfunction. So it is as similar as ferritin in COVID circumstances. So if you're not sure whether it is COVID or not, then ferritin is a clue. If you are sure that it is COVID, you can do D-dimer. dimers are elevated, then it suggests like there is a diffuse endotheliopathy, and this child, if when there is a diffuse endotheliopathy, obviously the child is at risk for coronary dilatation as well as organ dysfunction. It's a prognostic marker rather than a diagnostic marker, T dimer. So I haven't touched about IL-6 because IL-6 might not be available in many for practicing pediatricians or anybody outside. Mostly we do CRP, ferritin, local now in certain places it is now available. So I wanted to touch these three markers in detail. And
What is the cost for procalcitonin? Cost.
so cost is like in these centers it is around 2,500 to 3,000, sir.
Okay.
It's very costly, sir.
Okay.
If there are no other questions, thank you all for attending this session. I hope this session was useful to everybody, and thanks the Rainbow team for organizing this particular session. Thank you all.